So, in this session we will see about examination and evaluation of diabetic foot and diagnosing a high risk diabetic foot. So, diabetic foot is very important that we need to identify, we need to see who are all the patients at risk. So, if 100 patients we see, 100 diabetic patients we see in a day, 40% of them may not need anything at all. So, they may not have any high risk foot at all. But how do we know the other 60% are high risk, or where do we keep them, or how to know that these patients might go for a risk of complication or an ulcer, or we need to modify them, their footwear. So how do we evaluate, like which patient needs what, or which patient needs what, any intervention? So that is very, very important for us to in a clinical care, to know the high risk diabetic foot and evaluating these patients. So we will just go in a very, very stepwise manner. But before that, I would draw your attention to this particular study. It is one of the very, very good study where they prospectively studied. See, retrospectively when we study, we can know like the data will not be so high because there will be this confounding variables may not get addressed in a very effective way. But this is a prospective study among 7,000 people in northwest region of England. They aimed to determine what is the incidence of foot ulceration in these patients, in high-risk diabetic patients in a community health care. What is the incidence of foot ulceration in those patients, and which of the simple clinical foot screening methods widely used in clinical practice are most effective in predicting the risk of diabetic foot ulceration in the community. So they looked into various factors or various simple tests that we can use in our clinical practice, and which test or of all these things is useful to know which test predicts this high risk diabetic foot. So what they have done as far the first question is concerned is, the first question when they looked into about 7,500 people who of whom 6,600 people were responding to this survey for 2 years, 291 people developed foot complications. So which is about 2.2% is the annual incidence when they were followed up for 2 years. So this is the same incidence that we see in clinical practice. So if you are seeing 100 patients, 2 persons may be having a diabetic foot ulcer, but 40 people may be at risk, or 60 people might be at risk. So but 2% are the one who are at risk. So how are we going to avoid this incidence? By knowing like who are all prone for this foot ulcer is the one that the study tried to do. So the incidence is 2%, and which are all tests helped that. So the following factors were independently related to new foot ulcers. So they tried to assess the abnormal neuropathy disability score. They looked into this parameter, which for clinical purpose it doesn't need. Insensitivity to the 10 gram monofilament, which we will see shortly. What is the insensitivity to the 10 gram monofilament? Reduced pulses, which were associated with high risk of diabetic foot ulcer, obviously. The foot deformities also can cause, or the abnormal ankle reflexes also can cause, and age is not an independent risk factor. But the most important factor is the history. So if the ulcer is present at baseline, the patient may be prone for, or more prone for, developing a new ulcer where the odds ratio is about 5 times higher. Or if there is a past history of ulcer, the patient has got a higher predisposition to develop a new ulcer. So these two are the most important. So the first thing that we need to ask when it comes to this 30-second foot examination, I call it as 30-second foot examination, because we have so much of things to look into our patient. So we have just 30 seconds to look into the foot examination. How do we do that? The first thing that we need to know in our patient is the history. So history is very, very important, where like we need to ask this simple history, whether the patient has got an ulcer or healed ulcer, or this is the simple question that we need to ask. If the history is positive, then the patients are more predisposed for new ulcers. So the first question is history. The San Antonio Consensus Conference says that it has published a beautiful literature on peripheral neuropathy. So the diabetic neuropathy is a descriptive term meaning a demonstrable disorder, but they may be clinically evident or subclinical. So what we are looking at is not an evolved ulcer where it can be subclinical also. But when we mean by subclinical, it is not based on a single sign or symptom or test alone. There should be at least a minimum of 2 abnormalities from symptoms, size, nerve conduction abnormalities, quantitative sensory test or quantitative autonomic test. So whatever test that we do, there should be at least 2 tests for us to tell that the patient has got a neuropathy. So that is very, very important. So what are all the simple 2 tests that we can use? One is assessing the loss of protective sensation, because if the patient's protective sensation is lost, it means that his foot has become numb. When the foot has become numb, he has a higher predisposition to develop a foot ulcer. So we have to find out whether the patient's loss of protective sensation is intact or is it lost. Second thing is whether the patient has got a neuropathy or not. So neuropathy is present or not can be known with a simple 128 Hertz tuning fork is all that is needed for the patient. So these 2 are the simple tests which we need to do.